Hi everyone. Today I'm delighted to have a chat with Dr Stephen Tisch, the head of the Department of Neurology at St Vincent's Hospital here in Sydney. Dr Tisch studied medicine at the University of Tasmania, graduating with first-class honours, and focuses clinical practice and research into movement disorders and conditions like Parkinson's and dystonia, which is actually the context under which we met. He has authored or co-authored over 50 research papers and is conducting a new line of research looking for a cure of a disease called focal dystonia that affects professional musicians and sports people, often tragically at the height of their powers. That is the work we've been honoured in a very small way to be able to support. So without further ado, Stephen, thank you so much for taking the time to chat with us.
Thank you very much, Michael.
So neurology is a fascinating and deeply mysterious topic, certainly to people who aren't involved in it. Are there any things that are particularly surprising about working with the brain?
I think one of the wonderful things about being in the field of neurology is the interaction between behaviour and movement, and the fact that you get the opportunity when you take the history from a patient with a neurological problem to sort of learn more about them as a person. It's not as sort of unidimensional as, say, a sore foot or a pain in the kidney. You know, you're really coming to grips with the whole person because you're dealing with their neurological symptoms, but also their feelings, their emotions, their psychiatric well-being is sort of broadly within the banner of brain health. So I consider it to be a very rich and varied branch of medicine, and something that just, you know, never stops being interesting. So I'm very pleased that I chose that as my chosen field.
Right, so you able to tell us about focal dystonia, what it actually is, how it comes about?
So focal dystonia is a neurological condition which is characterized by involuntary movements that usually take the form of sort of cramps, spasms, or tremors, usually in one part of the body, hence the word focal. One example is a condition called writer's cramp, in which the hand and fingers will tense up, adopt abnormal postures. There may be tremor. And the effect of those abnormal movements is that it distorts the intended movement. So you're trying to write normally, but in actual fact, you're getting these altered, distorted movements which perturb the pen, so you can't write correctly. The writing becomes degraded. It might be shaky, less legible. It can also be very effortful and even painful for people with this condition. One of the more intriguing things about focal dystonias, including writer's cramp, is that they are often very task specific. So you can take a patient with writer's cramp and give them a pen, and they'll have obvious symptoms when writing. You can get them to type, you can get them to pour liquids, you could get them to do a range of other tasks, and you won't see any evidence of dystonia. So it's very task specific, in this case to handwriting. Another example of focal hand dystonia is musician dystonia, where again you see these abnormal movements, spasms and postures, usually in a hand, which may come on only when playing that professional's particular instrument and not at any other time. You can sort of infer that if it's a problem with movement that only happens with a certain task, it's pretty advanced, it's pretty sophisticated within the brain, and that's where we think dystonia is operating at a very high level brain processing. And you could consider it almost as a programming fault, where the motor instructions that are supposed to deliver the correct sequence of movements are being slightly corrupted, and you're getting a degraded and abnormal pattern of movement control, which then leads to distorted movements that we call a dystonia. So it's a very fascinating condition, and for the people that have it, it can be a very serious and disabling condition.
Right, so who's kind of most at risk of this?
Well, interestingly, the better you are at something and the more you do it, the more you slightly put yourself at risk of developing dystonia. So musician dystonia is particularly a problem for advanced or professional musicians because they're very, very skilled and they practice a lot. So the more practice, the more repetitive use of a particular task, you're sort of pushing the brain further and further. The connections become more and more advanced, more complex, and you can almost think of it as brain plasticity pushed a bit too far, and then things become unstable. So certainly people who do particular tasks a lot are somewhat at risk of developing these focal dystonias. It could be professional musicians. Some professional athletes, believe it or not, golfers can get a form of dystonia that affects putting. It's sometimes colloquially referred to as the putting yips. And there have been some great golfers over the years who have had their careers sort of sidelined a bit due to this. And in yesteryear, when handwriting was more of a thing, there were a lot more stenographers and scribes. Some professional handwriters, it was a career-ending event that, developing focal hand dystonia because they could no longer write.
And so how would it present for a golfer? Would the putt just...
Well, probably the most common manifestation of dystonia in golfing is related to putting. And it's usually when the golfer is attempting to address the ball with the putter. It's a very practiced and controlled movement. You'll start to see small jerks, spasms, or tremors, which are colloquially referred to as the yips, which then either angle the club or deflect the club or produce a false shot, which can, ruin the shot. And someone can go from a very advanced level of putting to almost sort of missing the ball or mishitting it. And it's obviously a devastating affliction in someone whose livelihood depends on their golf skills. And there have been golfers who have had that, and it's been a big problem for them. Getting back to that task specificity that I was talking about, some of the golfers have salvaged their game by changing the task. So they might use an extra long club. Some of those really long clubs have been outlawed now, but even changing the club to a broomstick club, because you're using different muscles, a different grip, you can sort of outsmart the task specificity and the dystonic symptoms might diminish or even go away. Certainly, I think golfers are a little bit at risk. I think some other sports can be slightly vulnerable to focal dystonias. I think it's been reported in pole vaulters. You have to get that very precise placement of the pole in the cavity for a successful jump. Believe it or not, other occupations can also be at risk, including hairdressers. They have a very great degree of facility and expertise in using their hands for operating the scissors. And that repetitive and precise movement can also put them at risk of developing focal hand dystonia.
Seem very consequential, pole vaulting and scissors. You wouldn't have shaky hands at the wrong moment.
Yeah, perhaps not.
Is this an age-related thing, or can it present in younger people as well?
It's a little bit unusual to present in children or adolescents and not then progress in some ways. So generally when children develop focal dystonia, particularly if they're before they've reached puberty, it's often a herald for further progression of dystonia, and many of those children will then see progression of dystonia to other body regions, and it may even become generalized.
What generalized be? Would that be in other parts?
Yeah, so it could travel. So it might start in their hand or their foot at a certain point in childhood, and then over the course of the subsequent years, other parts of the body start to become affected. Some of those children will end up having almost a sort of whole body dystonia that we call generalized dystonia. If an adult, a mature adult, particularly sort of 30 plus, develops focal hand dystonia, it's less likely to generalize. Sometimes we see some mild regional spread to adjacent body segments. And not infrequently, we see the association with tremor in various forms. There seems to be a strong link between tremor and dystonia. So it has quite a diverse age range of involvement, focal hand dystonia. It affects both men and women. And it does seem to have some occupational risk factors. There are probably also genetic and inherited risk factors, in that if you have a family history of dystonia, that probably puts you at increased risk of developing dystonia.
And so what are the options if somebody presents or comes into your clinic and says, I find it really hard to write or can't play the violin anymore?
Well, normally we go through it fairly carefully. We assess them in detail, try and be very confident that we're dealing with a focal hand dystonia case, if that's what it is. There's a certain number of things we need to rule out. Not infrequently, we'll run some laboratory tests or even brain imaging to make sure that there's no structural problem. Because interestingly, we talked about these dystonias being more of a software problem in the brain or a program not running smoothly. most of these patients don't have any brain lesion. So you can take an MRI and the brain's absolutely pristine, which is interesting.
What does that imply? Does that imply it happens in a very small location?
It implies that we're dealing with a neurochemical disturbance with a very minimal visible pathology. So in other words, there are very subtle changes going on within the brain that you can't see on an MRI that underline the dystonia, and they're probably happening at the level of neurochemical transmission, possibly at the level of the cells themselves in terms of their synapses. But these are very small scale events and not something that you would see on an MRI. So you can think of it more as a problem within the function of the brain rather than the structure. Right. But we often take an MRI of the brain just in case there's been some other structural problem that we weren't anticipating. But normally in these types of focal dystonia cases, the brain MRI is normal, but it's an important normal. And then we try to rule out any other reversible causes of dystonia. And if we've sort of come to the conclusion that this is a pure so-called idiopathic dystonia, meaning that we haven't found any other cause, it's just the dystonia, then we can start thinking about treatment, which could include tablets of one sort or another, medications to try and damp down these dystonic signals. They work to a varying degree. Another form of treatment is the use of botulinum toxin injections, the same Botox that's become wildly popular for wrinkles and cosmetic use. Long before it was in the hands of the plastic surgeons, it was being used by neurologists for treatment of spasms, contractions, spasticity, and tremor. And we still use it for that purpose by injecting minute quantities into specific muscles. So if someone with, not sure if you can see in my camera, if someone has writer's cramp and they're trying to write, and then they might get a particular pattern of abnormal movement, say finger extension like that, then we could potentially target the specific muscle that's extending the finger and get a relatively selective improvement in that muscle.
Right, so you just block it kind of downstream of the problem effectively.
Absolutely, you're quite right. Yeah, you've hit on it. We're not treating it at source, we're treating more the end result. But it can be surprisingly effective. And interestingly, you alluded to something quite important there, that these dystonias operate as sort of a circuit. You've got the central output, which we think is coming from brain networks that are delivering instructions for motor control, but you've also got the muscles and the joints. And they have a lot of sensation, and there's obviously a feedback loop. So the dystonia is sort of going from the brain to the affected body part, but there's also sensory information coming back and sort of a feed-forward feedback loop. And Botox in the muscles seems to work not only by reducing the force of contraction, it also seems to help reset some of that feedback that's abnormal. So you sort of see a kind of a downscaling of dystonic symptoms over time, and often those benefits accumulate over time with more and more injections. Right. Some people get quite good results with Botox and medication for focal hand dystonia, but unfortunately there's a substantial group in whom they don't really get reliable or adequate results. That was one of the reasons we were drawn to trying to develop some newer treatments for this. And that was sort of actually how I met you, Michael, through some of those discussions about the use of incisionless interventions.
I mean, I have a friend actually who has this. I was just telling her, I mentioned dystonia, and she said that she has a tremor as well, can't type, and has to plan her holidays and travel arrangements around where she knows she'll be able to get an injection. So maybe it's one of those things that's more common than you think.
Yeah, and I guess it's a bit analogous to someone with very mild Tourette syndrome who has a few tics. You can have a movement disorder and it's not always a big deal. One of our former registrars here at the hospital, I just happened to notice on a ward round that she had hand dystonia, and she goes, "Yeah, I do." Wow. And she was working at a high level and and she didn't really need treatment. So I think it's always good to keep it in some sort of perspective. There are shades of grey with all of these conditions, and generally the people that we're discussing that are a bit treatment resistant or who might be candidates for these more exploratory interventions probably are at the more severe end of the spectrum, where the symptoms are particularly disabling, very painful, very impactful for career and livelihood and those sorts of things.
So you ever talk about your research? What's your kind of approach to trying to find what was the phrase, non-incisional approach to treating the condition?
I've sort of stood on the shoulders of people much cleverer than me in many phases of my research, but I'm a rather practical person, and I'm attracted to things that work, that have a high efficacy level. And we've known for some time that these various movement disorders operate through abnormalities within signaling within various networks within the brain. And some of those networks are sort of now partially understood. And from that knowledge, which has been gathered over many years in various ways, we kind of have a sense of various regions within the brain that might be useful to modulate or intervene to try and diminish some of this abnormal brain activity that could reduce the symptoms. And there are a number of nodes within the brain that seem to be quite important in terms of propagating the abnormal movements in dystonia. And the regions that are particularly important are the basal ganglia and the thalamus, and also the cerebellum plays a considerable contribution. So one thing that's emerged relatively recently is the use of an incisionless ultrasonic apparatus to use high energy focused ultrasound to produce precision ablations within the brain. So you can think of it as like you can think of it, I don't know if you've ever messed around with a magnifying glass as a kid.
Maybe at some point.
At some point, most people have. Like, you take the magnifying glass on a sunny day, you hold it over a piece of newspaper or a leaf, and if you get the focal point of the magnifying glass just right, you can burn a little hole in the leaf. But interestingly, if you put your hand in between the paper and the hot area, it's not hot at all. So it's not hot except where the energy is being focused. Now, imagine an ultrasound machine with beams that can be focused to a point that we can then put the patient's head inside. And mind you, the hair is removed, but there's no incision. But if you can imagine those ultrasound beams passing through the skin, the scalp, and the skull, and then being focused on a specific point in the brain that we select, we can then use that ultrasound energy to produce a sort of precision ablation, a little area of heating, which results in some permanent change in the cells, which can break some of those circuits that are malfunctioning. And that can lead to very rapid and dramatic improvements in various movement disorders. But we're using it very effectively for tremor, and we've treated over 100 patients successfully with tremor using this technology.
Talking about Trevor, is that Parkinson's, or is that more generalized?
Some of them have had Parkinson's, some have had a condition called essential tremor, and a proportion have had dystonic tremor. So they didn't have quite as much of the abnormal postures and spasms, but they definitely had, appreciable tremor as part of their dystonia. And certainly MRI-guided focused ultrasound, which is this technology that I'm describing, has now a well-established role in the treatment of tremor. What we're hoping to do as of next year is adapt a similar approach, but rather than treating just tremor, we're going to start seeing if we can apply it for the treatment of focal hand dystonia, which is that condition we were talking about a moment ago. We have some confidence that we should be able to achieve meaningful improvements in hand dystonia by delivering a similar sort of therapy effect in a slightly different region of the thalamus, just a little bit more forward in the brain, a little bit more towards the midline. So we're just using a slightly different target location, and we feel in that location there should be a high probability of achieving benefit for patients with focal hand dystonia. So that's going to be the core of the project, and then all of the research is built around that in terms of studying the effects, how well it works, what are the changes going on within the brain networks, what are the impacts on the hand. We're very interested to work out if it's having any detrimental effects on hand function. So we don't want to have a treatment which is good at relieving the dystonia, but then leaves the patient with a clumsy hand. That's not a great treatment. So we're measuring all of those things very carefully.
And how do you know where to target? Are you able to see this on a scan or something, or is it just? Good
question. So we can see the outline of the thalamus very clearly on an MRI, but the subnuclei, you could liken the thalamus, so we can see the house, but we can't see the rooms of the house.
Right.
However, we know where the rooms of the house are because we know their geometric position from a brain map that's been worked out before from various atlases. So although we can't directly visualize the specific area that we need to see other than just seeing a point, we know from various other methods which compartment of the thalamus is likely to contain the cells that are active for the problem that we're trying to deal with. So we use MRI. We can certainly see where we're going. We can see the lesion that we're creating perfectly, very, very accurately. And in fact, we monitor the lesion throughout the procedure. So we can watch it grow from a very small spot to a larger spot. And that brings a lot of safety and control in that we know exactly where we're going and we can monitor the process in real time so that we don't do any unintentional damage.
Is the patient conscious during the procedure?
Yeah, fully conscious.
And so you kind of, what are they doing in their hands or the treated?
Yeah, so far with our tremor treatments, we're testing tremor and we're testing it very frequently during the procedure because that's a very good indicator of how much success we're having while we're doing the treatment.
Right.
When we start doing the focal hand dystonia patients, we're obviously going to have to test their dystonia, and that presents its own challenges. So we might, if they're a focal hand dystonia handwriting patient, we might get them to write. But if they're a musician, we might actually have to get them to play their musical instrument during the procedure in order to accurately assess what's going on. So we've got a number of models and ideas in mind of how we're going to be able to do that. An added complexity is whatever instrument that we choose for them to play on, it must not be magnetic because the MRI environment is highly magnetized, and any ferromagnetic objects will be sort of attracted to the magnet with great force and present a potential danger. So there's a lot to think about, but I think it's an exciting time.
So maybe a violin and not a trombone. Something like
maybe, yeah, exactly.
Go back to your room analogy. So is it the same for everybody? Like was it the thalamus? Don't know too much about the brain.
Pretty reliable. It's pretty reliable. So if you think of the thalamus as sort of like a 15 or 20 room house, sort of roughly box shaped. In the middle row, roughly sort of 2 rooms along, you're going to find an area that's fairly reliable for tremor. Those sort of coordinates tend to be true for everyone, right, by and large. Sometimes when we're doing the procedure, we need to tweak that position a little bit by a few millimeters to further optimize the treatment. But there's a surprising degree of consistency in terms of brain anatomy between different people.
Interesting. How did this treatment come about? What was the genesis of this technology?
It's almost like rejuvenation of a very traditional technique using modern methods. So even in the mid to late 1950s, lesions were being made in the brain using instruments, using probes passed into the brain, and then using electrical heating to produce a therapeutic lesion. So that was the old way of doing an ablation.
That sounds quite dramatic.
It's quite dramatic. It's very confronting because the hole needs to be drilled into the skull, an electrode needs to be passed down in the brain, and it's obviously relatively invasive for that reason. Those lesion procedures were, in many instances, highly effective. But they sort of gradually fell out of favour, and people were eager to develop a technique which would allow creation of lesions, but sort of non-invasively. And then it was really through pioneering work from a company from Israel called Insightech, partnering with an American company, GE, as well as some fantastic scientific minds, to bring to fruition MRI-guided focused ultrasound, which allows transcranial delivery of ultrasound to produce therapy lesions within the brain in a consistent and safe and reliable manner. And that system's now commercialized. We at St Vincent's have one of those commercialized systems. It's TGA approved, so it's passed the highest level of safety and stringency for a healthcare product in Australia. And there's a growing data for the effectiveness, particularly in tremor. But there are obviously new applications like dystonia, for which there's still very limited information. So we're hoping to be one of the groups worldwide on the cutting edge of this, new applications. and we'll be making our own contribution to science through those endeavours.
So what's the approval process then? Is it you can treat a number of cases, write them up, but the equipment's already approved? So once you've established the method...
We don't really envisage any barriers to approval for two reasons. One, the target is very similar to what we're using now for tremor. The second reason is many of these focal hand dystonia patients have a bit of tremor anyway. And our current approval is for thalamic lesioning for tremor. So they sort of indirectly fulfill existing criteria. The safety and feasibility is almost identical whether we do it for tremor treatment or dystonia treatment. As I mentioned, we're just changing the location of treatment slightly. And the patient group are a little bit different. But we are still going to go through a formal
Yeah, absolutely. So how many patients will be involved in these studies?
Well, I think in our pilot study, as it's sort of currently planned, would be somewhere between 10 and 12 patients initially, all with focal hand dystonia, all having unilateral treatment. By that I mean just ultrasonic ablation on one side of the brain for the opposite hand, because the brain and limbs are opposite.
It's exciting. So you do a lot of work in Parkinson's as well, I understand.
Yeah, no, I'm definitely, it's a big part of my workload.
We've kind of invested in the odd Alzheimer's company, and Parkinson's seems similar in the sense that so many things have been tried and so few things have worked. Why do you think I'm kind of lumping two things at once? So very welcome to take on one or the other, or both.
No, it's actually,
why are they so resistant?
Actually makes sense what you just said.
So why do you think they're so resistant to treatment and so many things are failing, and it's just, there's been so many leaps and bounds in other fields in medical research?
One's in Parkinson's disease, and then there are two that are about to start that are in so-called atypical Parkinsons, which, believe it or not, can resemble Parkinson's disease, but can in some ways be worse. One of these so-called atypical Parkinsonian syndromes is something called PSP, progressive supranuclear palsy, which is quite a daunting and confronting condition for people who have it. So, and then the other one that's also a very challenging condition that behaves a little bit like Parkinson's disease, but often progresses more quickly and has more impactful, is a condition called MSA, multiple systems atrophy. So with the Parkinson's work that I'm doing, sometimes I'll meet patients who have been referred for unusual Parkinson's or atypical Parkinson's, and then as things unfold, it transpires that they don't have Parkinson's at all. They in fact have one of these other conditions, such as PSP or MSA. So what we're trying to do at the moment is have sort of some treatment trials in place that we're participating in. I should add that I haven't been the designer or instigator of these trials, but I've tried to position myself in such a way that I can help run them and facilitate them by us being a site to bring patients into them, and more importantly, so patients can potentially access an emerging therapy, well before it reaches a commercialization, because these are really daunting diseases, and any sort of glimmer of hope in terms of a new therapy is often welcomed by patients. So that's another thing that I'm interested in.
Absolutely. So what are the trials actually trying to assess? Are they new treatments? Are they trying to figure out who's got what?
No, they're more saying, okay, well, we'll take a group of patients that we're pretty confident have this particular disease, and we'll give them one or more drugs in a controlled way, and then we'll measure a number of outcome measures over time and see if there's any improvement in their condition that would provide an indication of benefit or disease modification. So the goal with all of these studies is some signal or hint of disease modification, which is clearly the holy grail in this group of disorders, because at the moment, none of them are curable.
What's the standard of care for Parkinson's at the moment?
Well, Parkinson's is sort of a bit of an outlier in these neurodegenerative conditions, partly because its rate of progression in pure Parkinson's is considerably slower than some of the other diseases that I've spoken about. In addition, there can be tremendous symptomatic benefit in terms of relief of symptoms using particular medications, particularly medications based around dopamine neurotransmitter.
Right.
And for that reason, people with Parkinson's, even well-established Parkinson's, can look very well and function at a very high level, often for many, many years. So in a way, the drugs can work extremely well for quite a long time, and the patient can remain in the mainstream of life. So although they have this neurodegenerative condition, they can still be very well managed and very well looked after. That's probably, as a clinician, one of the attractions of treating Parkinson's disease, because it has a much more positive side to it in many ways. Insofar as you can do a lot of good in Parkinson's if you identify symptoms, target symptoms with appropriate therapies at the correct stage of the disease, and you can often keep people really very well and in a very positive state for a very, very long time. So that's a sort of a hopeful message that I send about Parkinson's. So even though we're not at the point of being able to offer people a concrete cure that they can hold in their hand, Parkinson's disease is highly treatable, even with our existing therapies.
Right. Are there any trials or treatments or avenues of research that you're particularly excited about?
Look, I definitely think that drug discovery trials are really important for the reasons I mentioned.
And that's the ones that you're doing as well, right? Are they new drugs?
Yeah, I'm sort of just a node within wider networks, but we're sort of contributing to some of those studies, which is useful. I'm also interested in interventional therapies, including we talked about the focused ultrasound, but also deep brain stimulation, which is a more traditional neuromodulation approach for movement disorders. It's more invasive than focused ultrasound insofar it involves implantation of electrodes into the brain to modify the neural impulses to improve motor function. It can be extremely effective for a wide range of movement disorders. And that's been a long-term research interest of mine to better understand DBS, the mechanisms of DBS, also the outcomes of DBS, trying to predict who will respond so that we can match DBS effectively for different patients at different stages of their disease and get the highest quality outcomes. So that's been another area of research interest for me.
How long does that last? Does that treatment last for the patient?
For some. Yeah, for other conditions, the benefit may be not as long lasting. So we talked about Parkinson's disease. DBS has a very important role in Parkinson's disease, but it's not a cure for the underlying degenerative aspects. Right. So the patient might derive excellent benefit and improvement in quality of life for 5 to 8 to 10 years. But then the progressive aspects of the disease eventually catch up, and then other problems supervene. And the Parkinson's might become sort of overwhelming due to the progressive effects. But for the period of time that the DBS is working, the patients benefit substantially.
So you've covered a few areas of research. Are they your main research focus? So dystonia and DBS. Are there other projects you're working on and that you're looking to progress?
We're also just doing some smaller projects in the area of botulinum toxin, which is a neurotoxin used to treat movement disorders. We're also doing some smaller projects in a relatively rare but important condition called FXTAS, which stands for Fragile X-Associated Tremor Ataxia Syndrome. You may have heard of Fragile X syndrome affecting as a leading cause of intellectual disability in boys. There's a genetic variant of that spectrum which affects adults, mainly men, but some women. And they're not intellectually disabled. They later in life develop a tremor and unsteadiness. And we've had a particular interest in this condition for a number of years and have a special clinic for that condition. So we're sort of continuing to extract knowledge from the patients that we've seen with that condition, and that's been another focus of research.
Right. What's the approach there? Is it one of the techniques you've already talked about? And when these drugs come out, like are you approached by pharmaceutical companies that are doing trials and looking for patients?
Sometimes we are. Sometimes we're approached directly, and then we have to not exactly make a pitch, but we have to present our experience and our capabilities in a favourable light, so that the commercial pharmaceutical company feels confident to entrust us with carriage of the study as a site, to do the study properly and to have enough patients to kind of get the results they're looking for. We've been, reasonably successful in doing that in a range of projects, and I've got some fantastic neurologist collaborators at St Vincent's who arguably do a better job than me at attracting pharmaceutical research. So I think we have a good track record in that field.
I guess it's so amazing you then offer these experimental treatments to patients as well. Absolutely. Well, that was kind of an uplifting note after talking about quite a number of quite serious conditions.
Yeah, I mean, it amazes me how people who are in the grip of very serious and progressive diseases still have strong altruism and want to turn a negative into a positive. It's a very, very good thing.
Oh, well, thanks so much for taking your time out of your schedule to have a quick chat with us.
Oh, thank you. And I'm very appreciative of our discussions and things that we've talked about, particularly in relation to focus ultrasound and hand dystonia. And I know that that's something you've been interested in. So I really appreciate your interest in that project.
Absolutely. Looking forward to seeing the results and hopefully successful, but otherwise very happy to be a small part of it. Thanks so much for taking the time.
My pleasure, Michael. Thank you.
Hi everyone. In this episode, I was delighted to have a conversation with Dr. Stephen Tisch from the Neurology Department of St Vincent's Hospital. Dr. Tisch is working on a cure for dystonia, a rare neurological disorder that affects professional musicians, sports people, and calligraphers, amongst many others. We met at a fundraising dinner last year with about 15 similar projects, all with significant unmet medical need proposed. Sadly, the majority went through unfunded, and those lines of research were not pursued. If you'd like to support scientific research like this, please feel free to contact Nicole Forrest Green at the Foundation directly, and I've added the details in the show notes. Hope you'll find this as fascinating as I did.